Hello friends, this is a case of one of the simplest way of performing the laparoscopic myomectomy for pedunculated myoma. This patient has 15 centimeter myoma, but it is completely subserous and pedunculated. So, you can easily perform this. We are putting various needles supraumbilical and this is suction irrigation or hanging drop test just to make it confirm that the various needle is inside the abdominal cavity. After that, we are starting the pneumoperitoneum. Here flow rate is 1 liter per minute and preset pressure is set to the 15 millimeter of mercury pressure. So, this is a young unmarried girl with the pedunculated 15 centimeter myoma and supraumbilical port is introduced and we are waiting for pneumoperitoneum to get completed. So, now pneumoperitoneum is slowly increasing. We can see distension of the abdomen is visible and approximately 3-liter gas was introduced and now various needle will be removed. After that, we will enlarge the incision to 11 mm to introduce the optical port and reason of being it supraumbilical that you can have a panoramic view and especially during morcellation panoramic view is important. So, if you put the telescope in the umbilicus, it will not be possible to have a wide view and then you can injure the nearby organ. So, incision is enlarged to 10 mm and now first the optical port will be introduced. So, this is the optical port, that is 10 mm port we are introducing and slowly it is going inside the abdomen. After that, gas is reconnected and now the maximum flow rate is increased to 10 liter per minute. Telescope is inside and after having initial diagnostic laparoscopy, we will put two ipsilateral 5 millimeter port. So, this will be according to baseball diamond concept and it should be approximately 18 centimeter away from the pedicle of the myoma. So, these two are only 5 mm ipsilateral port. However, the lower port which we will put 5 mm later will be increased for morcellation. So, this is the second working port that will be your right hand for the ligation or harmonic and this is the third port which is approximately 1 centimeter above the anterior superior iliac spine and that will be used left hand for the myoma screw or for the grasper or during the suturing for the Maryland to facilitate the suturing. So, carefully both the port is introduced and now head is 30-degree down and we will start the surgery. So, we can see this is a large myoma which is filling up the pelvic cavity, but it is pedunculated. You can see the pedicle. However, pedicle is very small, it is subserous. So, we will not use here the knot, we will directly inject the vasopressin. We can see this is right ureter and just lifting the myoma up, we are injecting the vasopressin, that is 5 international unit of vasopressin is diluted with the 20 ml saline and it will be injected at the junction in the uterus to get a transient ischemia so that bleeding will be minimum. So, vasopressin is having the best known vasopressor agent and it will create the blanching. We can see blanching of the uterus is started and it will also facilitate the hydrodissection. So, this is now done. After that, we are lifting the myoma and this is cutting with the harmonic at the junction. We have to protect both the tube because this is unmarried girl. So, better not to go near the tube and with the harmonic we are excising the myoma. So, these are very simple cases. The problem happens once it is intramural. Subserous fibroid you can do within 5 minutes without any problem. However, if it would have been really fully long pedicle, then we can try the Mishra's knot, but here it is not completely pedunculated with the long pedicle, it is subserous with the small pedicle. So, now we are using little bit ligature on the simple so that hemostasis will be achieved and then you will not have any bleeding. But initial incision of the serous layer should be by the harmonic because harmonic is a scalpel. So after that you can use ligation to catch the pedicle so that hemostasis will be achieved. And we can see very easily it is just detached from the uterus and it is cutting out. We can see one more myoma, a small myoma intramural is there. That also we will remove of this one, which after removal of this large one we will remove that also. So left hand is giving anterior traction and right hand is cutting the myoma from its base to the attachment of the uterus, and now it is almost out. And it is removed. After this intramural myoma also we will remove, because if you will leave it later it will increase in the size and it will press the cavity. So it is easily coming out. And you will keep in the right iliac fossa, so later it can be safely taken out. After that we are using here the barb suture, and suturing is started. Here we will do the double layer suturing. The both the layer will be seromuscular, because it is not a deep intramural, so you don't have to suture the muscle separately, and barb suture will hold the serosa and muscle together. So we should start the suturing at the healthy tissue on the clean surface without incision, and then it will start. Barb suture has already a loop, so starting is very easy. And now continuously it will be sutured and seromuscular layer will be approximated together. At least 1 centimeter lateral to the margin of the incision you have to take a bite so that it will not cut through. And the advantage of barb suture is that it is unidirectional, so it will not slip back, and you can approximate the edges. So left hand you should hold the suture so that it will give traction, and continuous suturing is done to just approximate both the edges. So deep muscular bite should be taken. If you are doing serosa and muscle together, if you will take superficial bite it will cut through. And with the deep bite we can see once you will tighten it, it will approximate and it will not return back. So edges are approximating. Now we will further continue. We should take care that bite should not be taken near the tube, otherwise intramural part of the tube may get blocked. So we can see left tube is below, and you should avoid holding the tube as well. So these type of cases are very simple. Size of the myoma is not important, location is very important. So it was located at very convenient place. So surgery is easy. And now we will return back to take the more enforcement. So just this is reach, and now returning back. 3 4 bite you will take, and just before the termination you should take a deep bite, because barb suture you don't need to tie a termination knot, but when you are doing to the last bite it should be in a deep muscle, so that any tip of the barb should not be projected outside, because it has a tendency to catch the momentum or bowel. However, we will put interseed here at the end, so that to prevent any adhesion. Interseed is very good in those cases, because in young patient there is a tendency that fimbrial end or the tube or the omentum or the bowel can adhere. So deep bite is required before termination. So we can see hemostasis is achieved, and now it is done. After that, before cutting the suture, we should suck all the blood which is in the cul-de-sac or hair bear. Little maximum 2-3 ml blood is there that you can suck, and then you can cut it. Irrigation is also good before cutting the suture, because suture will act as a traction. So you can lift the uterus. Here we are not using even the uterine manipulator, because patient is unmarried and all the fluid, and it is washed, pelvis is washed, cul-de-sac is aspirated with the local lavage. More lavage should not be done, and any blood should not go to the upper abdomen. After that, with the ligature we are cutting the suture without leaving any tip, and then needle will be taken out, and after removing the needle we will put interseed. So this is interseed which will cover the rough area, and it is a mechanical adhesive barrier that doesn't allow any adhesion to happen. So we should put it all along the incision site, and once you will press it, then it will stick with the uterus, and this fluid will not allow it to displace, it will remain stick there. So just gently pressing it over the uterus, it will take the fluid from the uterine serosa, and it will not displace, it will remain there. It get absorbed within 2 weeks of the time, and by the time serosa will repair, and there will be no any adhesion. So surgery is over. After that we will do morcellation. Here it is a large myoma, so morcellation bag will not be used, and because it is a young patient, so directly we can morcellate. Morcellation is sometimes time taking, so we will not show you the entire morcellation process. And after morcellation, this port should must be closed, because not closing these ports can create the hernia. So this is the morcellation port is bigger, so it should must be closed. So this is finally end of the surgery. So thank you very much for watching this video. Have a nice day. This is one of the very simple myomectomy which you can perform by laparoscopy. It has a lot of advantage. Patient has faster recovery, minimum pain, early return to work, and scar also will not be there. Thank you very much. Have a nice day.